Good morning, everyone. Welcome to Medicine Grand Rounds. As a reminder, this is the last Grand Rounds of our academic year. We're going to take a hiatus and actually won't have Grand Rounds next week or the week of the 4th of July, but then we start our summer series the week after that. And Heidi tells me that the schedule for that will be coming out very shortly. So keep your eyes out for that because we have a great lineup for the summer. So this morning, it gives me great pleasure to introduce Dr. Josh Keller to speak at Medicine Grand Rounds. Dr. Keller is a graduate of our residency program and currently is a rheumatologist at Rheumatology Associates here in Portland, along with his wife, Katie, who was also a graduate of our program. So for those of you that didn't overlap with Josh, I just wanted to let you know his background. Josh went to Adelphi University for his undergraduate degree and then obtained his medical degree from SUNY Upstate Medical University. Did his residency at Maine Medical Center in internal medicine, was a very successful resident, was also successful in the matrimonial sense as he and Katie met and got married, and they left after residency, both to do fellowships in rheumatology at the University of Kentucky. And fortunately for us, they both returned to Portland along with their growing family. And we're very, very pleased to have Josh back today to speak with us about an approach to inflammatory arthritis. Josh, thank you for being here.
You're welcome. So again, I'm Josh Keller. Just going to talk today about an approach that you might take to a patient with inflammatory arthritis or that you might suspect might have inflammatory arthritis. So first, I have no disclosures to speak of. In terms of learning objectives today, first, I'd like to kind of discuss and define inflammatory arthritis for everybody. Then I'd like to teach you how to identify presence of inflammatory arthritis in a patient, and then review components important in the history and physical exam about that inflammatory arthritis, and in turn discuss the different subtypes of inflammatory arthritis and just figuring out what underlying cause there might be to that patient's inflammatory arthritis. So what is inflammatory arthritis? Our first learning objective. And this is, of course, Socrates. So generally speaking, it's when the immune system is activated towards a component of the joint or joints, mono or polyarticular arthritis, and that part of the joint can be the synovium or the cartilage or the synovial fluid. And it could be an appropriate process, like if you have a septic joint, maybe a destructive process, but still an appropriate response, or it can be inappropriate in the sense of an autoimmune inflammatory arthritis, which is what we most often see in rheumatology. So when you see a patient, the patient says, "Doc, I have arthritis." And what they really mean is, "I got pain somewhere," not necessarily arthritis. And that pain, it might be coming from the joint. It might be coming from a slew of other areas. So within the joint is what we would term arthritis. There's areas around the joint, periarticular areas, which include the tendon, tenosynovium, bursa, and the muscle. And then there's areas that are a little bit further away, like the bone. And then there's extra-articular causes for pain in an area, which could be neurologic or central pain or referred pain. And then, of course, this component of psychiatric causes as well, potentially. So this is just a good representation I found that kind of just showed the arthritis would be this joint, the cartilage, the synovium, versus the areas around it or central. So And so this patient comes to you with pain or arthritis or, joint pain, joint area pain. The most important lab test to then check at that point is the history and physical exam. And that's basically the way that we diagnose arthritis or inflammatory arthritis. So important aspects of the history and physical exam, the history to isolate arthritis is, ask the patient, where's the pain? Often patients will say it's my hands hurt. So I'll tell, if they say my left hand hurts, I'll say, well, take your right finger and point to where the pain is, because it might be the entire hand, it might be a specific on the joint, or it might be along certain tendons. They might have a flexor tendon nodule that's causing trigger finger and pain, and really isolating where that pain is coming from will help you. So the other thing to note is an arthritis should have symptoms moving in all directions, not just a single direction. So if they say every time I, put a book up on the shelf, my shoulder is killing me, but they say, oh, I can do the dishes and my shoulder doesn't hurt. That's a clue in the history that it's a certain movement of their shoulder that's causing the pain rather than all motion of their shoulder. And it really should be all motion of a joint if it's an arthritis. So, and then it's hard on history sometimes, but you can try different things in terms of passive and active range of motion, in trying to figure out whether or not passive range of motion is also affected. The important thing on passive range of motion too is do they have full passive range of motion? You should have full passive range of motion. If you don't, there's likely something wrong in the joint, whether or not it's inflammatory or not. And then, is there an effusion? So, swelling is something that I always ask on history. I'm not sure I always trust the patient's interpretation of swelling, but it's always, I'm looking for effusions in the physical exam if they're telling me there's swelling around a joint. So trying to figure out if there's an effusion. If it's a non-inflammatory effusion, it's probably from another abnormality in the joint, another like non-inflammatory cause. So if there is an effusion, there's probably an arthritis. Okay, so once you're confident that in history at least, pretty confident it could be, that the patient has an arthritis, then in the history, what are things that are important to try to figure out if it's inflammatory? So, we often talk about prolonged morning stiffness, and that prolonged morning stiffness should really be longer than 60 minutes. So patients with osteoarthritis will often say they have morning stiffness. And then if you ask them details about it, how quickly does it go away? What do you do to make it better? They'll say, oh, well, I get up in the morning and I kind of shake around and it's much better after 15 seconds or 10 minutes or something like that. Our patients with inflammatory arthritis who have a morning predominant pain or stiffness will say, oh, it's improving a few hours later. I feel best in the afternoon. Of course, there's all different variable options in the middle. And it's, I guess, least helpful when a patient says it's exactly 60 minutes, but really trying to figure out, is it prolonged for several hours? Is it, 10 to 15 minutes or less? That's helpful in trying to figure out if it's an inflammatory arthritis or not. Improvement with activity. So sometimes patients will say, on mornings where I just kind of get up and it's Saturday and I just sit in the couch, it lasts for 5 to 6 hours. On mornings where I get up and I go for my morning run, it improves in an hour and a half. So that's also really important to try to figure out what, if it helps with that, if activity helps the arthritis or the symptoms that they're having, or if activity makes it worse. So, going up and down stairs, doing a run, a jog, if patients say, oh, I can't even do that, it's worsening, or, doing dishes just kills my hands, then that's a clue it's probably not an inflammatory arthritis. So in terms of back pain, that's inflammatory, axial spondylitis. Often patients will say that it wakes them up at night. They can be up for hours at a time trying to get back to sleep. Non-inflammatory back pain, while it can wake patients up at night, they'll often say, oh, I can shift around and then, I'm able to get back to sleep pretty easily, pretty quickly. So that's one clue, even though they can both wake patients up at night. If it's a throbbing, long pain for a long time at night, keeping them up, that's a clue on that it might be inflammatory back pain. So, doing the history, this is kind of the approach I take. I first try to figure out if a patient has inflammatory arthritis. And then I really delve into deep on that inflammatory arthritis, all the specifics about it. We all were probably taught or like different algorithms for asking these questions. There's the old cards and the OPQRST. Whatever works for you, but really trying to figure out all those specific historical aspects of that inflammatory arthritis that you think they have. So was it abrupt onset, meaning they said, oh, doc, I was fine the night before, and then I woke up, I couldn't move my hand, or whatever joint they're talking about, versus, I kind of noticed one day that it was stiff, and then thinking back, it's kind of been coming on for a month or two. So that's an important part because that really changes our differential. And then how long, so acute, subacute, chronic, how long it's been present can also really change what we think might be the underlying cause, for sure. Often, to note, things that are chronic were once acute. So over time, our differential can change. And then what happened before, a common thing to ask directly would be any preceding illnesses. Did the patient recently travel somewhere? Did they go to a tropical region where they might have been exposed to chikungunya or some other potential cause for their inflammatory arthritis? So getting what happened before this is also important. Now, what joints are involved is also helpful. If it's one joint, that's the knee, I'm in a very different spot in my mind in terms of thinking through what this inflammatory arthritis might be versus 3 MCPs on both hands. So really just identifying what joints are involved is very helpful in figuring out if it is one inflammatory arthritis versus another. Now, the time course, it's really important to note, did the symptoms completely go away in between episodes? If the patient reports episodes or flares, sometimes patients will say, oh, it flared up and then it improved. And, delving into it, the patient will say, well, it never really got that much better. It was maybe 40, 50% better, and then it got bad again. And that is very different than if they say, oh, I got this terrible arthritis, and then after a week, it just went away. I was back to normal. And then, 2 months later, I got another episode of, red, hot, swollen, say, ankle. And then after a week or two, it kind of went away again. So that's helpful because all these different diseases have different characteristics and likely presentations. Migratory is another type of inflammatory arthritis that's really important to figure out from the patient. So if they say, my elbow, they give a really classic history of inflammatory arthritis of their elbow. And then after a period, it completely went away. But then at the same time, they started to get an inflammatory arthritis of their wrist. And then it started to improve before it completely went away. It started in their knee. So that kind of leads us down a decision tree that's a lot smaller in terms of what might be causing it compared to other types of inflammatory arthritis. And then the character. So, and this is kind of just a natural thing that I'm sure we all ask, but it's just important to really get the specifics from the patient, whether or not it's like a dull, achy stiffness versus red, hot, so tender you can't put a sheet on it. And, I'll often just put whatever questions I feel I'm able to figure out how tender it is or how stiff it is. So if the patient states, I couldn't even put a sheet on my shoe, on my feet at night, I'll put that in the note, and that's also a good representation of how exquisitely tender that might be versus, I couldn't go on my run, but I could walk around fine, So it's important to kind of figure out how exquisitely tender it is or how swollen it is, and just the specifics there. Again, what happened right before it. So I'm just thinking about gout with the abrupt onset, red hot, super tender. If the patient states, I had a bunch of scallops and beer the night before, that really helps us figure it out probably pretty quickly. But if they give a history that is concerning for, say, gout, you want to ask that directly. If you have a concern about a specific cause and there's a historical thing you would expect, you want to ask that directly. And then, has the patient tried anything? Often patients, by the time they get to us, they're prescribed something before they get to us in rheumatology. But there's a lot of things they might get over the counter, or they might get from urgent care or from some other doctors. So figuring out, okay, did it respond at all to ibuprofen or naproxen, or if they got any prednisone or anything. And also figuring out, do they have any recent medication changes, or are they on any medications that are concerning for a drug-induced syndrome like drug-induced lupus or drug-induced vasculitis? So that's just part of the history of any medical syndrome, but for inflammatory arthritis, it's quite important. Okay. So in terms of the review of systems, I will typically, we have for new patients, we have a questionnaire that kind of has our rheumatologic review systems on it, but I'll definitely ask them specifically questions directed towards a specific subgroup of inflammatory arthritis if I'm concerned for that type. And I kind of, in my mind, separate out the review of systems based off of the different inflammatory arthritises. So there's, my spondyloarthropathy questions, my connective tissue disease questions, and I'll go through a lot of the ones that I ask if I'm concerned about these in a patient. So if I'm concerned about spondyloarthropathy, I'll ask, any red or painful eye episodes, and you really have to make sure that the patient understands you mean the white of your eye, of their eyes. Often they'll say, oh yeah, I get kind of redness down here, and you say, no, it's the white of your eyes. Is that ever red and painful? And then you also want to ask any episodes of sun sensitivity with your eyes, or where you have to wear sunglasses inside because your eyes are just really sensitive to light. That's a concerning sign that they could have had uveitis or have uveitis if it's ongoing. So, and that could be associated with spondyloarthropathy, especially an anterior uveitis. Episodes of dactylitis, I'll usually ask a patient, do you have any episodes where a finger or a toe or a couple fingers or toes are really swollen like a sausage, much bigger than the other fingers, and really tender, hard to move? And I feel like that often will I'll get an answer that I trust, versus if you just ask, hey, you have any finger swelling at times, because that'll almost always get an answer of yes. So, sometimes with the episodes of dactylitis, it'll be, if they have it ongoing, it'll usually be evident when you walk in the room. But you want to, and this is part of the review system, so just asking about episodes they may have had in the past. Then you want to figure out, do they have any history of psoriasis, or any potential rashes that are undiagnosed that might represent psoriasis. The important part with that as well is to ask them about fingernail changes or toenail changes. Because often, I've had a couple patients where their only psoriasis might be oil spots or onycholysis of their fingernails, but they have a presentation that goes along definitely with psoriatic arthritis, and their fingernails is the manifestation of their psoriasis. For the IB, inflammatory bowel disease questions, you want to ask about chronic diarrhea, history of bloody or black stool, if they've had any diagnosis, but if they've had any colonoscopies or endoscopies in the past and why they've had them. Mouth ulcers is also, something that we would see in an inflammatory bowel disease. And then urethritis or preceding illness, those are questions directed towards like reactive arthritis. So connective tissue disease is a huge group of diseases, but there's a lot of overlap in that group. So a lot of these questions can apply to multiple diseases in the group of connective tissue diseases. So fever, mouth ulcers, lymphadenopathy, so big swollen lymph nodes, easy bleeding, which we would usually associate with thrombocytopenia potentially. Photosensitive rash. So again, trying to see that if they had a rash on their face after sun exposure, which shouldn't go away in a day or so. It should really be present for weeks, probably, minimum of a few weeks. Any blood in the urine or pain with urination, just thinking of lupus nephritis or, other types of nephritis or interstitial cystitis. Patients might just say they've had, a lot of UTIs lately, and then you really have to, your antennas have to go up wondering if they have undiagnosed early nephritis. So just that's a question to ask if you're concerned about that. In terms of, the pregnancy history, I often will ask it just thinking of any phospholipid syndrome antibodies, especially history of miscarriage, small for gestational age birth, any history of DVT or PE. I've had a couple patients with a lot of lupus manifestations, but just an antiphospholipid syndrome antibody. So it's something to think about as well. Pleurisy. So any episodes of like chest pain with a deep breath or a cough, but otherwise not having a ton of chest pain. The Raynaud's, muscle weakness, because you can have a lot of overlap with, even if they have lupus, they can have some component of myositis. They don't have to have polymyositis or dermatomyositis to have manifestations of myositis. And then skin thickening for and sclerodactyly for scleroderma. Shortness of breath, of course, you can have ILD with a lot of these diseases as well. So rheumatoid arthritis, extra-articular rheumatoid arthritis manifestations usually would occur in patients who have long-standing untreated rheumatoid arthritis, but sometimes it can come before the primary manifestations of the disease or at the same time. So you can have RA lung, RA ILD, so shortness of breath and cough. In terms of eye manifestations, scleritis would be a more common presentation with rheumatoid arthritis, although there is a lot of overlap in what they can present with. So the sclera should really be, if you have scleritis, red, injected, and that can become a severe emergency. So it's important to really have that patient see ophthalmology really quickly and or rheumatology if you think the patient has scleritis with or without rheumatoid arthritis. Any nodules under the skin, so rheumatoid nodules, extensor surfaces, just asking if they have any bumps under the skin. There is a subset of patients, again, usually in longstanding untreated rheumatoid arthritis, but Felty syndrome, patients will often have a low neutrophil count with frequent infections. So, if you don't have labs yet and you don't know about the neutropenia, you can ask about the frequent infections, whether or not they've, always are getting antibiotics from somewhere because of frequent infections. And then dry eyes and dry mouth. So, primary versus secondary Sjogren's. A lot of patients with rheumatoid arthritis will have lymphocytic infiltrate in their salivary glands, and they'll have Sjogren's without the Sjogren's antibodies, so we call that secondary Sjogren's. So you can get the manifestation, the psychosymptoms and the manifestations there of Sjogren's with rheumatoid arthritis. So that's one thing to ask, directing the review systems towards that. And then, things, if you're concerning about infectious arthritis questions, So, if there's any preceding or concurrent rash, just thinking about parvovirus, patients who might work in a daycare, that would be really important to always ask. Mothers who have a lot of children at home, or fathers, anybody who has a lot of children around, that would be important to ask. And main and important thing to ask about the rash would be because of Lyme. It wouldn't be likely ongoing at the time that they would have Lyme arthritis. So you would ask about a preceding rash in that case, or tick exposures, as you all know, probably. A lot of people won't remember any tick exposure, even if they have Lyme. So you can ask, and it's good if they remember it, but it doesn't rule it out by any means. In terms of gonorrhea, chlamydia, syphilis, you want to ask about genital ulcers or lesions, urethral discharge, pelvic pain, recurrent fever. So just thinking also about like SBE, which can cause inflammatory arthritis as well. And then, that's another thing with the bacteremia. You can have recent infectious symptoms as well, causing a seeding of that bacteria into the joint. And then direct trauma. So a patient, do they work in the garden a lot? And do they get a lot of thorn punctures in the area that might have directly inoculated the joint with a potential pathogen? That's important to ask. So, in the review system with the crystalline arthritis, you might be seeing the patient, if this is their kind of disease activity of their arthritis. You can't see my pointer, but the line going up and down is their symptoms. You might be seeing them at the tail end of this, where they're kind of describing more of a waxing and waning course when you're initially asking the questions. So it's just important to also ask, was this ever kind of an intermittent arthritis, or were your symptoms ever intermittent, where they were there and then away completely and then back again? Because even though gout has the classic presentation of there and then gone in 7 days, or pseudo gout similarly should be there and then gone, these diseases can both kind of morph into more of a chronic waxing and waning arthritis, in which case you really want to get that remote history. Do they have any white, yellow bumps under the skin, which, tophi? They can be on the ears. They can be on, the skin here. I've seen a lot of tophi in a forearm on a patient who had really bad tophaceous gout. So they can be basically anywhere, usually more in the periphery. So, forearm, hands, lower extremities, below the knee, ears, but they can be pretty much anywhere. It's just important to kind of look at, because you don't want to not look and not ask the patient, because they might point you to a spot that you don't usually check, where it's just sitting right there and that's your answer. Kidney stone history. So often patients with hyperuricemia, they're often predisposed to kidney stones as well. So just making sure they ask them about that. And that won't give you for sure the answer, because a lot of people have kidney stones, but it can kind of push you up or down on your betting, so to speak, on what this might be. And then osteoporosis. That's more thinking about pseudogout. There is a subset of people with osteoporosis who have hyperparathyroidism. It's not always diagnosed. So you just want to ask about osteoporosis or hyperparathyroidism, because that is a potential predisposing factor for pseudogout as well, the hyperparathyroidism part of it. So, and then, patients that have, because there's always atypical presentations of certain diseases, and we don't want to miss something like giant cell arteritis. So if I have patients in their 80s, or, definitely over 70, and depending on the presentation, over 50, I ask my GCA questions as well. So headache, scalp tenderness, the way I ask that often would be, when you're taking a shower and you're shampooing your hair, do you notice any tenderness in your scalp, any jaw pain? So it should be with eating just simple foods, not just like, eating really hard candies. It should be just eating regular foods. They get jaw pain, kind of the muscle getting sore. tongue pain. The tongue is another muscle, and that can also get ischemic, so to speak, from GCA. So something to think about there. And then the way I ask the vision questions is visual disturbances. And I'll say, do you have any episodes where you lose vision in an eye, even for a very short period? Do you have any episodes of double vision? Any episodes where you feel like a shade is coming down, maybe it doesn't even go away all the way. You don't want to miss anything like that. And then for younger patients, you want to make sure you just take a sexual history, because that is higher prevalence in that demographic. Okay. So what else? So in terms of just approach to patient, I usually go over past medical history. Do they have psoriasis listed? Do they even remember that they had a little patch of psoriasis 15 years ago? So just going through their past medical history on the chart review and with them, just to kind of review potential clues. A lot of these we already talked about. Social history, so tobacco use. In terms of rheumatoid arthritis, which is one of the more common inflammatory arthritises, tobacco is basically the biggest reversible risk factor. So that might help you kind of put this patient into a higher or lower risk category in your head. And then IV drug abuse, sexual history in terms of risk for hepatitis, HIV, gonorrhea, chlamydia, occupation history, patients who the distributions of arthritis are kind of classic in most patients, but certain patients might have different distributions of osteoarthritis, I guess in particular, like plumbers, electricians, they might get osteoarthritis in MCP joints. Or in occupation, the other thing to note is if I have a patient who's in healthcare, I'm gonna really make sure I double check that they haven't had any needle sticks. I'm just thinking about potential needle stick transmission of hepatitis, HIV. And then travel history, we already talked about a little bit. Family history, it is important, it is a part of the puzzle. Even if your identical twin had lupus or rheumatoid arthritis, you'd have a 15 to 30% chance, and that's the same genes, of having those diseases. That's a lot more than the baseline population risk, but it's not 100%. So it's the family history is important piece of the puzzle, but just note that it doesn't predestine people to have a disease because they have a family history of the disease. And then surgical history and medication reconciliation. So the med rec is important, like I mentioned, because just thinking of lupus, drug-induced lupus, and also, certain diseases, you want to know if they're on diuretics, say, because there'll be a higher risk of having gout, hyperuricemia, if they're have a history of diuretics. Okay. So now you're moving on to physical exam. So to confirm it's arthritis, you really want to isolate that area that the pain is and really figure out, is it the entire joint? Is it just part of the joint? It really should be the entire joint. If it is an arthritis, that's has the symptoms, whether or not it's stiffness or pain or whatnot. If it is an arthritis, it really should have the symptoms present with passive range of motion, presumably pain. So it shouldn't just be active range of motion that really points more towards a tendon or a muscle or a periarticular structure if it's only active range of motion causing the pain. So really trying to isolate that passive, active, or both. Is there full passive range of motion? And this is really helpful, I think, for certain joints that not being a rheumatologist, you probably don't examine all the time, or it's really difficult to tell if there's swelling, like say the wrist or the elbow. So if a patient, you can't tell if they have swelling, but they can only move their wrist 20 degrees up and down, flexion extension. That's the lack of full passive range of motion is really concerning and really indicative of a potential arthritis in that joint, which you might not be able to tell given just it's a learned process how much swelling there might be, especially certain body habituses. Is there an effusion present? So like I mentioned, an effusion really helps to say there is either either a non-inflammatory arthritis or an inflammatory arthritis present or recently present. So that's helpful to kind of isolate whether or not there's an effusion present. Now, in terms of trying to know if there is joint swelling, and if you don't, just trying to give some advice on trying to do a joint exam, if you can feel the joint versus not feel the joint is a helpful way to have a somewhat good idea of whether or not there's swelling. If you can't feel the joint, just thinking about like MCPs, PIPs, DIPs, wrists, and elbows, if you can't feel it at all, then that's a good evidence there's probably swelling. Versus if you can feel it, then you kind of get more into the, is there extra tissue there? Is it kind of mushy or not? So a good thing you might tell a rheumatologist in your note, or put in your note if you want a consult, would be, unable to palpate joint line. That really is a good indication to us that there is joint swelling there or an effusion. And then, the signs of inflammation, or redness, warmth, tenderness. If there's a red hot joint, particularly 1 or 2, you really have to think of septic arthritis. I mean, crystalline arthritis is higher on the differential of what it might be, but you have to be concerned about dangerous things first. So 1 or 2 red hot joints, you got to be concerned about septic arthritis, which can destroy a joint in just a couple days. So it's an emergency. Is it an inflammatory arthritis? So you do the first part of your exam and you're like, yeah, there's an arthritis here. It kind of the things I was just talking about: warmth, swelling, redness, tenderness. Those are kind of the things that might help us figure out whether or not it's an inflammatory versus non-inflammatory arthritis on exam. In terms of the swelling, there could be joint hypertrophy, bony joint hypertrophy, like Heberden's and Bouchard's nodes, and osteoarthritis. So I kind of put the pictures of the gummy bears and the jawbreakers here. So when you're feeling the joint, you want to kind of see if it's a mushy type, rubbery feeling versus kind of hard bone underneath the skin that's just larger, which would be more indicative of osteoarthritis. And then, are there any deformities? So, swan neck deformities, boutonniere deformities, Z deformities, hitchhiker deformities. So if you see deformities, that's a really, if the patient doesn't report a injury with a snowblower or something, then, you really gotta have an explanation for those deformities. And inflammatory arthritis can damage a lot of the tissues around the joint and in the joint and cause those deformities. So that's, even if you don't see an active inflammatory arthritis, if you have the deformities, you're really suspicious for a history of it. And again, just trying to reiterate, 1 to 2 red hot joints, septic, and crystalline arthritis, you got to think of those really quickly. So in terms of when you're pretty sure it's inflammatory arthritis, you want to then say what joints are involved, because that can help us in the future figure out what type of inflammatory arthritis it might be, and how many joints are involved. 1, 2, 3 joints is a lot different than polyarticular 7, 10, 12 joints in terms of what might be going on. Symmetry is also very helpful in helping us figure out what might be the underlying cause. Small, medium, large joints, peripheral versus axial. And then not just the joints, you want to do a good exam of the eyes. We talked about history and review of systems. So look at the sclera, have them look around so you can look at all areas of it. Look for psoriasis, behind the ears, the belly button, the lower back. Look at the fingernails, feel the lymph nodes, and look for mouth ulcers. Listen to the lungs. So do a normal internal med physical exam. And putting it all together, I like to tell patients, well, these are all just pieces of the puzzle. I have to put everything together and we have to figure out, and it almost certainly won't all be present, all the pieces of the puzzle right away. So it might take several visits or months, or, sometimes even years to kind of figure out what the underlying diagnosis might be. You can put as much of the picture together as you can at the time, but it might take time to get all of the information together and figure it all out. So just in turn, I've talked about a lot of these already, but an abrupt onset, so really quick onset, patient says, I woke up and my toe was red, or I kind of felt a twinge, and then 10, 12 hours later, I had this, pain, redness, swelling. That really points us towards crystalline and septic arthritis is likely possibilities, especially a single joint. And then the insidious onset, we think of more connective tissue diseases, spondyloarthropathies, and rheumatoid arthritis. I'll get into the differential for mono versus oligo versus polyarticular. In terms of time course, we talked about really trying to ask a patient the questions to figure out migratory versus additive versus waxing and waning. A migratory arthritis has a pretty short differential. Gonorrhea, meningococcal, Whipple's disease, early Lyme, but it usually will progress pretty quickly to kind of land on a knee or both knees, or a knee and an ankle. One single knee is the most common Lyme arthritis. Rheumatic fever and subacute bacterial enteritis and sarcoid. So it's not as long of a list as a lot of our other potential presentations. Insidious onset, that is probably our biggest group. It's basically everything else. So rheumatoid arthritis, all the connective tissue diseases, spondyloarthropathies, sarcoid obviously can also present that way. And then typical Lyme would kind of be this slowly growing knee that patients report. And then the intermittent crystalline and palindromic RA, which we do see, which would be a very aggressive kind of look. It seems almost like a gout or pseudogout crystalline arthritis, but no crystals are identified, and often it is seropositive. So the other thing to note is if a patient has one red hot swollen joint, even if they have a history of rheumatoid arthritis or psoriatic arthritis, you really need to take the fluid out of that joint and look to and send it for culture if it's highly inflammatory, like over a 50,000 cell count. There's a lot of patients with rheumatoid arthritis who also get septic joints because the most common joints that get infected are abnormal joints to begin with. So you don't want to anchor on their prior diagnoses. You want to really always think of this as a possibility. Anything that's red or hot, you should really have a needle going in that joint to take fluid out of it. So just quickly going to talk about gout. These are the typical monosodium urate crystals on polarized microscopy. It is where you have these crystals, and without getting into all the details, it will cause an upregulation of IL-1 beta via an inflammasome and cause a very highly inflammatory process. While we do classically think of it as one, sometimes two joints, patients, as it progresses over time and it becomes more severe, patients often get a cluster, so to speak. So they might have, a wrist with one or two MCPs and a PIP. So this kind of whole cluster, this whole area might be in a gout flare. Or they might get an ankle with an MTP, and then like a tarsometatarsal joint, a midfoot kind of flare. So it's not uncommon that we'll see 3 or 4 joints in an area that's all flared up at once. It doesn't, it rarely, I've had a few patients, but it rarely affects patients, males under 30 years old. And the other thing to note is a premenopausal female is really, really a low risk for gout. If you do have a patient, premenopausal female that you're concerned might have gout, ask a good medication history, see if she's been on hydrochlorothiazide. Make sure she hasn't had a total hysterectomy 10 years ago, essentially postmenopausal at that point, because she should be in a really low risk category. Females, uric acid in their blood doesn't tend to rise until after menopause typically. The other thing to note is the serum uric acid. It typically will go down during a flare. So patients who have a current active inflammatory arthritis shouldn't get a serum uric acid checked. And when it is checked, it puts people into low and high risk categories, but it's not a way to diagnose a patient. And you can say a patient whose uric acid is 15, extremely likely to be gout versus someone whose uric acid is 3. But it doesn't diagnose it. The way to diagnose it would be to take fluid out of that joint and look at it under polarized microscopy. So pseudogout, really quickly, it is, at least in acute pseudogout, it is the same kind of IL-1 mediated inflammasome reaction. It could also have a lot more chronic course sometimes, mimicking rheumatoid arthritis or other chronic inflammatory arthritis. This is a polarized microscopy, more rhomboid shaped crystals. This is blue along the polarized light axis. Monosodium urate crystals are needle shaped and they're yellow along the axis. So in terms of pseudogout, the important thing, because we don't have, number one, because we don't have medications that directly address it, is to look for underlying causes. The other thing to note is if a patient has an underlying cause that you found, it kind of can increase your thought that it might be pseudogout and you're thinking through the differential diagnosis. So hyperparathyroidism is one of the most common underlying causes, but hypomagnesemia, hemochromatosis, and then hypophosphatasia, which is a alk phos, not phosphorus. Septic arthritis. So like I had mentioned, within a few days, septic arthritis, gram-positive cocci septic arthritis will just totally destroy cartilage. So it's really important to get that addressed quickly. So in terms of synovial fluid, white blood cell count and differential that you would be really concerned for septic arthritis, so anything over 50,000, often we'll see 100,000, 150,000. I had a patient where the lab just stopped counting. They had over 350,000. They just kind of stopped. And a lot of polys, over 90% polymorphonuclear cells. Chronic monoarticular arthritis, so patients who have one joint that's been present, so swollen, tender for more than 6 weeks. Differential narrows somewhat because thinking the acute inflammatory monoarticular arthritis also has all the chronic arthritis possibilities in it. So in that regard, you just have to wait long enough for it to become chronic. So chronic monoarticular arthritis, indolent infection is something that we often think about and have a really low threshold. Some rheumatologists always will get a synovial biopsy, but really low threshold to get a synovial biopsy to rule that out. You can send synovial fluid for cultures, but the sensitivity isn't nearly as high as a synovial biopsy. So, often we'll send synovial fluid cultures if we can get enough synovial fluid. And if it's negative, then if we still have a suspicion at all, we'll send a patient for a synovial biopsy. Tumor, and then the other, atypical presentations of rheumatoid arthritis, spinal arthropathies. Lyme in this area is really high in the differential, especially certain joints like knee, ankle, mostly knee, but knee and ankle, Lyme is really high in the differential. And patients should have a positive Lyme antibody test because Lyme arthritis is a late manifestation. So while Lyme antibody tests can be negative early in the disease course, arthritis is a late manifestation, so it should be positive. And, we can often send patients to IR or orthopedic surgery, but, IR can do the ultrasound guided synovial biopsy on certain joints, which is kind of nice. So Lyme arthritis, it is weeks to months after presentation. So like I said, the antibody should be positive, and it will often settle in the knee, even if in the beginning other joints can be involved on history. Usually patients will have a huge knee effusion, and the pain that they have is almost mostly, I think, from the just pressure on the synovial on the synovium. If I'll just drain the fluid and they'll feel a lot better. So it's kind of a interesting subset where it's really a volume thing in terms of their symptoms. It is quite inflammatory in terms of the synovial fluid, but it's a large volume effusion typically. Treatment would be a month of doxycycline, and sometimes patients require a second month. There's a really small subset of patients where they still have a chronic inflammatory arthritis despite 2 months of antibiotics. It's additional antibiotics at that point isn't really helpful. So we would usually start an immunosuppressive medication, and then it often will go away and we'll taper off the medication in 6 months to a year or two. So we are, as you'll likely experience, we are in the Lyme endemic area. So oligoarthritis, septic and crystalline arthritis, like I've mentioned, are still in the differential, but goes a lot lower once you're on more than one joint with either of those diseases. So spondyloarthropathies is mostly what we see in the oligoarticular arthritis. Spondyloarthropathies, psoriatic arthritis, reactive arthritis, ankylosing spondylitis, IBD associated, and then enthesized related JAA, but I'm an adult rheumatologist, so I didn't include that one. So patient with psoriatic arthritis, this is a patient I actually saw several months ago. This is kind of a mostly dactylitic finger. So the swelling isn't just on the PIP joint, it's along the finger. And then the toe is to the end of the toe. So you can clearly tell that her right fourth toe there is a lot larger than her other toes. And then also her thumb, if you see her two thumbs next to each other, her right thumb there, IP joint is very swollen as well. So this is a kind of a classic case that I saw of psoriatic arthritis. Her scalp had, very classic psoriasis in it. And it's not symmetric, as you can tell, at least in some of the joints there. I didn't have pictures of her other hands here and toes. So reactive arthritis, so look at the eyes, oral ulcers, enthesitis. So this is a Achilles tendinopathy, and ankylosing spondylitis. So, there's a few tests that we do, simple ones to think of is, just cervical neck range of motion. Can they touch their shoulders with their chins? If they're standing with their heels and back against the wall, can they get their head to the wall? And then there's the Schober test where you're looking at expansion of the lower spine. So in this, which is the axial spondyloarthropathy presentation primarily, they get ankylosis of their spine potentially and their SI joints. So this gentleman here, he's standing up against the wall and he can't get his head any further back towards the wall. Typically, we should all easily be able to touch the wall. So acute polyarticular arthritis, viral, first thing that you think of would be like a viral arthritis. So again, those daycare workers, asking about rash, asking if the children had the slap cheek rash, parvovirus. And then any IV drug abuse history, any potential needle sticks, if you're in the medical field, just thinking of a hepatitis and HIV. I've had several patients with hepatitis C that without checking the hepatitis C, you would think has classic RA, MCPs, PIPs, swollen, stiff, really morning predominant inflammatory arthritis. but they're hepatitis C positive, and they're usually, a lot of mine, the ones I've had actually, are rheumatoid arthritis, rheumatoid factor positive as well, which could be from the hepatitis C, and the treatment would be to treat the hepatitis C. They could also have rheumatoid arthritis. So, we all would check a CCP, and if that's positive, that would also kind of put them at a higher risk of also having rheumatoid arthritis. But often, if it's just a rheumatoid factor and hepatitis C, if you treat the hepatitis C, it should resolve. And then, you can have a pretty explosive onset of rheumatoid arthritis, but usually it is insidious in onset. For vasculitis, I have a patient where she presented really aggressive onset polyarticular arthritis, and there was a few petechia that she had, and I checked an ANCA, and she ended up having GPA and subsequently developed renal failure. So you can, in vasculitis, have a really aggressive, abrupt onset, severe polyarticular arthritis as well. Polymyalgia rheumatica, patients will often say, I was fine the night before, I woke up and I couldn't move my shoulders or my hips. So it's pretty abrupt onset most often in polymyalgia rheumatica. And then sarcoid can almost do anything, but it can often be pretty abrupt onset, especially if you're seeing sarcoid in Lofgren syndrome, which it most often is an acute onset. I'll try to wrap it up quicker here. So chronic inflammatory arthritis, which is the biggest group of patients that we have, rheumatoid arthritis, all the connective tissue diseases, psoriatic arthritis, which while being oligo-articular, typically can definitely present in a classic RA-like presentation, and then hepatitis C, as I mentioned. So for rheumatoid arthritis, I just wanted to point out, this picture on your left, which is like an early rheumatoid arthritis patient. You can see that you don't see the normal extensor tendons over the MCPs and the peaks and valleys. You can tell that her PIPs, or his or her PIPs, are kind of swollen there compared to what you would expect. This is early rheumatoid arthritis. We want to catch a patient there rather than an advanced rheumatoid arthritis where they have the ulnar deviation, MCP subluxation, and all the deformities that you see in this second picture on the right here. So it's easy to tell the second picture is rheumatoid arthritis, but we don't want it to become easy to tell. And then lupus, while it can definitely have inflammatory arthritis, you're really looking for other things like acute lupus rash, any of that blood in the urine, recurrent UTIs, evidence that they might have lupus nephritis. Ask the patient, have you ever been told you had low blood counts? So those are other manifestations in the lupus, which is the most typical connective tissue disease that we think of. So I just wanted to end on this quote, medicine is a science of uncertainty and art of probability. So I'll often tell patients, I'm pretty certain. I usually I like to give a percentage, like I'm 85% certain you have this. There's still a lot of other possibilities. We're still putting the pieces together, still getting additional information. It's a complicated field, but it's fun to kind of get all the different pieces of the puzzle and put them together and see how confident you can be in what's going on and trying to help the patient in figuring out what they need in terms of treatment. And I primarily just used a textbook and up-to-date. Okay. How do I end this? Are there questions?
Looks like there are two questions in the chat. One from John Gilboy, one from John Erickson. Can you see those?
Yep. So can you please clarify the role, so this is from John Gilboy. Can you please clarify the role of serum uric acid in gout, acute flare versus chronic management? When you said it can be used for risk stratification, did you mean for future attacks once person is quiescent phase? So so it depends how certain you are whether or not the patient has gout. If you're, if you're seeing the patient and they're having an acute flare and they have a red, hot, tender joint, depending on how comfortable you are with that joint, it's best to get fluid out of the joint. And that's the way that you prove whether or not they have gout. If they have a history of flares and you're seeing them between episodes, then that would be a time to potentially get a uric acid. And you can put them into a higher and lower risk category in your mind of what they might have. If I have a patient with a very palindromic intermittent inflammatory arthritis and I'm getting it on history, but I don't see any active inflammatory arthritis today, and I get a uric acid and it's 3, then it really decreases the likelihood of gout in my mind, because I know it's not active today and I know I can trust that uric acid. So that's the way I use uric acid. If it's flaring, then if I'm trying to diagnose it, I put a needle in and I try to diagnose it. If it's not flaring, then I might use the uric acid to help risk stratify. And I'll tell the patient, if it's flaring, come back. You could still have gout with a uric acid. I think the lowest I've heard is 3, but you can still have gout with a uric acid that's not quite elevated, 6 or something like that. But it's not common. So that's the way I use uric acid. And now the way to utilize it in treatment would be to have a goal uric acid. And, if someone has tophi, recurrent kidney stones or erosions on x-ray, then our goal is typically 5. If they don't have any of those things, but they have gout, then our goal uric acid is 6. And you always want to make sure you're checking it not during a flare, because during a flare it could be falsely low. Or if it's flaring, if you have another process, it could be falsely high. So if you have a viral syndrome or something causing higher uric acid, it can be falsely high compared to your true baseline. So that's the way that I utilize uric acid in my practice. Question regarding steroids and the generalist. When do you think the generalist could or should not consider injecting steroids into a painful joint, and when could or should not the generalist consider prescribing prednisone for joint or muscle pains without the involvement of a rheumatologist? Yeah, that's a good question. So it's very patient dependent for me on whether or not I inject joints, and I think it depends for you as a generalist how comfortable you are injecting the joint. So certain joints, a lot of people probably feel quite comfortable, like knee injections. Shoulder injections, if you don't know your landmarks and how to do it, you run the risk of popping a lung, so to speak. So you don't want to do anything that you're not quite comfortable doing, because there are risks going into arteries or nerves or other potential risks like I just talked about. So it depends on your personal comfort level. In terms of whether or not you should inject a joint medically, if you know what's going on and you feel comfortable, like if someone has if they have bad gout, they don't want to go to a rheumatologist, and they have a bad knee flare and they have diabetes and kidney disease, and you don't want to use colchicine, NSAIDs, or prednisone, then I think injecting their knee makes total sense. So, I think in terms of generalist versus a rheumatologist injecting, I don't think there's a reason you shouldn't inject if it's clinically appropriate, if you feel comfortable injecting that joint. Did that answer the question?
Well,
I guess.
I'm not sure if Dr. Erickson's still there, but Josh, thank you very much for such a comprehensive and thoughtful review. This was really, really very clinically focused and I think very helpful. So thanks very much.
Oh, thank you. All right.
Bye now.